Hello and welcome into the endocrinology lectures. In this lecture, I will talking about disorder of thyroid gland. This lecture is presented by Dr. ZUHAIR. In this lecture, we have to reach objectives to identify the classic symptoms of hypothyroidism and hyperthyroidism, to identify the cause of hypo and hyperthyroidism, to list the assays used to assess thyroid functions by means the laboratory finding in thyroid profile. So, thyroid disorders or the disorder of thyroid gland. The disorder of thyroid gland may be borderly categorized based on newly tissue growth, neoplasm, or caused due to autoimmune mechanism or autoimmune disorder, and levels of hormone production. So, most of disorders of thyroid gland have categorized in these three main categories due to abnormal tissues growth in thyroid itself, such as neoplasm, or the disorders or the dysfunction of thyroid may be caused due to autoimmune mechanism, and the levels of hormone production from the thyroid gland itself. So, in the left column here, the three are the causes of disorders of the thyroid gland as neoplasm, which include the thyroid cancers, goiter, nodules, and autoimmunity disorders of the thyroid gland, which include Graves' disease, Hashimoto thyroiditis, and other autoimmune disorders. Insufficiency of production of T4 and T3 is also due to a primary hypothyroidism or secondary hypothyroidism when the production of T4 and T3 is low or insufficient. When I said hyperproduction or hyperthyroidism, also the cause may be due to primary hyperthyroidism or secondary hyperthyroidism, and I will mention each cause previously in this lecture and in detail. So we go on to the slide, next slide. What is the euthyroid? We also hearing most of the profile of thyroid function as well as become normal in level, and some of it which comment or interpreted as the euthyroid. So what is the euthyroid? By the definition, the term euthyroid refers to a thyroid gland that is functioning true. That means it is good, have no disorder here, producing adequate amount of thyroid hormone by means T4 and T3 in response to stimuli from the pituitary. Euthyroid is also used to categorize patients whose laboratory results for assessing thyroid function fall within the laboratory reference interval, no test results or normal test results. This by mean the euthyroid, normal function of the thyroid gland. Here in the next slide, hypothyroidism. Here we're talking about the signs and symptoms of hypothyroidism. So the features of hypothyroidism, the symptoms and clinical features of insufficient thyroid hormone production, that mean by low production of T4 and T3 or hypothyroidism, are considered generalized or non-specific in nature when evaluated singly. However, when elevated collectively or evaluated collectively, the present a picture the point to root cause and the underlying condition, so as to investigate the other causes such as TRH, TSH plus T4 and T3. Those presenting with hypothyroidism will frequently present with inability to lose weight, intolerance to cold temperatures, and chronically fatigue. Low level of thyroid hormones contribute directly to decrease and inefficient metabolism, leading to obesity and high blood pressure. Untreated hypothyroidism lead to cognitive impairment and depression. So, in this slide, there is two columns. In these two columns, column number 1 show the symptoms, and the other column show the clinical features of hypothyroidism. In symptoms of hypothyroidism, which also include the patient is also fatigue, sensitive to cold, constipations, that mean difficult to pee out or fees or stool to come out, dry skin, unexplained weight gain, puffy face, hoarseness, muscle weakness, elevated cholesterol, joint pain and stiffness, heavy menstrual periods, thinning hair, impaired memory, difficult to pack some of memory, swollen neck glands. In the clinical features, the patient become to the clinical or to the physician also have the clinical features such as obesity, have infertility, joint pain, high blood pressure, heart disease, depression, and cognitive impairment. Hypothyroidism, primary versus secondary. So has this a comparison between primary hypothyroidism and secondary hypothyroidism. The causes of hypothyroidism are broadly classified as primary and secondary. Primary hypothyroidism is also related to the defect or disease of the thyroid gland itself, and are further delineated below. The most common cause in autoimmune mechanism, where the body perceives healthy and normally function thyroidal tissue or products as foreign and attacks them. Primary hypothyroidism related to the thyroid itself. When I said primary hypothyroidism, that by mean the defect occur in the thyroid gland itself. The causes of hypothyroidism or primary hypothyroidism may be due to autoimmune interference with productions, insufficient supplies to make the hormones in the thyroid gland, defective or blocked receptors, faulty processing of hormone synthesis. These causes or all these causes occur within the thyroid gland itself. Secondary hypothyroidism is attributed to an insufficient stimulation of the thyroid, so as the factor or the main factor of hypothyroidism due to hypothalamus or pituitary connection, which lack or deficient in producing of TRH and TSH, which can lead to low or insufficient stimulus of the thyroid gland to produce T4 and T3. So, in secondary hypothyroidism, the main defect here by the TSH or thyroid stimulating hormone that coming from the pituitary gland. Secondary hypothyroidism related to the pituitary or hypothalamus, lack of stimulus, insufficient TSH production from pituitary. This is the most common. Insufficient thyrotropin releasing hormone TRH produced from the hypothalamus is rare. Here, what is the difference between primary and secondary hypothyroidism? The primary hypothyroidism, the main cause of low T4 and T3 is come from thyroid itself. That means the defect in the end organ by mean thyroid gland, which has or it's failure to produce sufficient amount of T4 and T3. When the defect come from the pituitary due to reduction or lack of TSH production, this is also known as the secondary hypothyroidism. When the defect is also occur in hypothalamus that have defect to produce TRH, when the TRH is the main cause of TSH production, here we'll call this is tertiary hypothyroidism. So again, when the TRH is low, this is tertiary. That is also occur in hypothalamus. When the TSH low and insufficient due to pituitary gland, here is secondary hypothyroidism. When the defect is also occur in the thyroid gland itself, not response to TSH or TRH to produce T4 and T3, so as here the definition known as primary hypothyroidism. This is the main difference between primary, secondary, and tertiary hypothyroidism. Hypothyroidism subclinical. What I mean by subclinical hypothyroidism? Okay, as the name implies, period to the onset of ovary clinical symptoms, that mean the patient asymptomatic, no have ovary clinical signs and symptoms. The laboratory finding may be provide a clue as to the development of a condition, such as the case with subclinical hypothyroidism, in which the circulating level of TSH are mildly elevated, but thyroid hormone T3 and T4 are still within established reference interval. So, in easy way, what is the subclinical hypothyroidism? When we do the thyroid profile in the lab, and the patient comes without signs and symptoms or before developing to signs and symptoms of hypothyroidism, when I measure the TSH, T4 and T3, here the TSH, when the result is elevated or mildly elevated or in the upper reference range of the TSH level according to the established reference interval, is also TSH is mildly elevated, and the T4 and T3 results are still within the normal range. Here, that means the patient will come into the next or near future will go on to hypothyroidism. Why? Because the TSH is mildly elevated. That means this patient maybe have a lack of iodine and maybe will develop in next future to low production of T3 and T4. Besides that, the test is still T4 and T3 is still normal in the established normal. This is also known as the subclinical hypothyroidism. So the typical result in subclinical hypothyroidism, TSH is mildly increased, T4 and T3 within the normal range or reference interval. It may help to recall the mechanism of thyroid stimulation. The pituitary attempting to release an increased amount of TSH to trigger the thyroid to produce more hormone. But from a laboratory standpoint, the measured amount of thyroid hormone appear as well within the reference interval and are not showing to be decreased or in need of further stimulation. For this reason, TSH is often used as a fourth-line test to identify disorders of the thyroid gland. That means the patient will come soon or will develop in near future to hypothyroidism due to mildly elevated TSH. Subclinical hypothyroidism may be progressed to ovaried hypothyroidism. That might mean in near future. But the time frame varies from person to person. If the underlying cause is identified and remedied, the condition may be referred to euthyroid state, as I mentioned it previously for the euthyroid state. Some patients with subclinical hypothyroidism may be dismissed some of the early non-specific symptoms associated with hypothyroidism, such as inability to lose weight and constipation. Hypothyroidism incidence and risk. Hypothyroidism is a prevalent disorder predominantly affecting females in adult population. That means when compared the hypothyroidism prevalence or disorder between male and female, the female is the most affected by the hypothyroidism than men. Incidence of hypothyroidism estimated as high as 15% of population. At risk population for hypothyroidism, that the risk factors for patient or for population to come of hypothyroidism, which include the female over age 60, family history of other autoimmune disorder, type 1 diabetes, arthritis, pregnancy with 6 months, receive neck or chest radiation treatment, previous neck or throat surgery, living where iodine deficient in environment, or living in environment with low iodine intake. Hypothyroidism laboratory finding. So when the laboratory result for TSH is found to be elevated above the established reference interval and free level of T4 or T3 are low. This is a typical results of hypothyroidism. These findings support a diagnosis of a primary hypothyroidism. When the result is TSH is high or elevated and T4 and T3 is low or decreased, this is a typical result of primary hypothyroidism due to defect of thyroid itself to produce T4 and T3. Is not respond to TSH production or stimulus by TSH, so as the thyroid failure to stimulus or stimuli due to TSH release, so as it is failure to produce T4 and T3. This is a typical result of primary hypothyroidism. So what is a secondary hypothyroidism typically result finding? Here the vice versa is correct. That means the TSH is low and T3, T4 is low. This is the secondary hypothyroidism due to TSH low, and according to the TSH low, the thyroid lack of production of T4 and T3, and this is also known as a secondary. And in a primary, the T4, T3 low and TSH is high. So the TSH is low and the level of T4 or free T4 and free T3 are also low or normal. These findings suggest a secondary cause of the hypothyroidism. Finally, an elevated TSH with normal level of free T4 and free T4 in absence of overt clinical symptoms is interpreted as subclinical hypothyroidism. When the TSH is elevated but the T4 and free T3 is normal, this is also known as the subclinical hypothyroidism. Here in this table show the laboratory finding and interpretation of result. Hypothyroidism and laboratory finding. In the column number 1, this is a TSH, 2 free T4, free T3, and interpretation of result. Here, when the TSH is high and the free T4 is low and free T3 is low or normal, this is a primary hypothyroidism. When the TSH is low and T3, T4 low or normal, free T3 low or normal, this is also known as secondary hypothyroidism. Why? Because the TSH is low here. Why? Because the TSH is low, so as the interpretation is secondary. Here in the first, high TSH is a primary. In a low TSH is secondary. When there is a high TSH but normal T4 and normal T3, this is also known as subclinical hypothyroidism. Hypothyroidism treatment and monitoring. Primary hypothyroidism is commonly treated with prescription supplementation of cyanide thyroxine. Because not all immunoassays for free T4 and equivalent at measuring synthetic form of synthetic thyroid hormone. Adequacy of thyroid hormone supplementation is monitored using TSH. So as in the period of treatment, we have to monitoring the patient of hypothyroidism by measuring TSH, which is also give a clue or more informative about the treatment and monitoring of the treatment. Recall that all circulating T4 level rise. The design of the negative feedback loop should be the pituitary response with the decreased production of TSH level. Thus, normalize TSH levels in conjunction with the improvement of hypothyroid related to symptoms severe as a guide to physician that dosing is adequate. If TSH level fall below the therapeutic range, the amount of thyroid hormone treatment may be reduced. Or if TSH level remain elevated, thyroid hormone supplementation may be increased. Monitoring frequently is often patient specific, but is typically performed on a monthly to semi-annual basis, depend on symptoms. The conclusion or the summarization of this slide, we have to follow up the patient with hypothyroidism by doing only one test is TSH. When the TSH after treatment that become normal, that means the treatment is success. When the TSH is still elevated, that means the physician should be increase the supplement or increase the treatment level so as to help thyroid gland to produce T4 and T3. When the TSH become low, that means the thyroid gland is response to the treatment and start the production of T4 and T3, and also the negative feedback occur to suppress TSH, and the result become of TSH is low. That means here the treatment is success. So the monitoring for patient of hypothyroidism is also done by specific done of TSH, and the monitoring should be done monthly and semi-annual basis on the patient signs and symptoms. Note that such hormone supplementation to the treat hypothyroidism with ongoing monitoring is likely a lifelong course, unless an underlying cause of lack of hormone production could be identified and correct. In this illustrative pictures show us the relation between hypothalamus, pituitary, and gland, thyroid, and tissues. When the treatment is success, the TSH level become low or become within the normal range. When the TSH is still elevated, that means the patient have no go on a right way of the treatment, and that should be visit the physician again so as to increase the supplement so as to help the thyroid gland to production of T4 and T3. Here we have the practice question. Which of the following would be considered among the classical symptoms of hypothyroidism? It is an easy question. In this question, what is the most classical symptoms of hypothyroidism? You can select only one answer. A. Intolerance to cold temperatures. B. extreme lack of energy. C, inability to lose weight. D, all of the above is correct. Which one of these is correct? Okay, good. The feedback: hypothyroidism is characterized by a number of non-specific symptoms, which include the inability to lose weight, tiredness, lack of energy, and intolerance to cold. This is the correct answer. So go on. In the other cause of thyroid disorders, here I will start talking about the hyperthyroidism. So what is the hyperthyroidism and clinical signs and symptoms? Much like hypothyroidism, the symptoms of hyperthyroidism are generalized and non-specific when elevated independently, but present a classical set of findings when evaluated collectively. Typically, those with hyperthyroid or hypothyroidism, the thyroid function become hyper and high secrete of T4 and T3. So, hyperthyroid function present with undesired weight loss, a high degree of anxiety, and intolerance to high temperatures. This is the signs and symptoms of hyperthyroidism, which is the completely opposite to hypothyroidism. The clinical features of hyperthyroidism include pong eyes, cardiac complication, and inflamed skin lesion. In this table show the signs and symptoms of hyperthyroidism. Symptoms include increased appetite, weight loss, sweating, nervousness, anxiety, irritability, insomnia, that means difficult to sleep, heart palpitation, that means by increased heart rate, shakiness, heat intolerance, light sensitive or sensitivity, eye pain, skin thinning, fine brittle hair. Clinical features include pulling eyes, that means the eyes become out and enlarge, pulling eyes, ophthalmology, swelling at base of neck if there is due to disorder or cancers or nodules, red swollen skin, heart problems, osteoporosis, and feverish. This is the signs, symptoms, and clinical features of hyperthyroidism. Hyperthyroidism, primary versus secondary. Hyperthyroidism may be referred to as thyrotoxosis, that means high production of T4 and T3, or toxic level of thyroid hormone being produced, similar to hypothyroidism. Causes of hyperthyroidism may be due to broadly categorized as primary and secondary. Primary hyperthyroidism relates to the thyroid gland producing large amount of hormone due to either uncontrolled growth of hormone producing functional tissue or by way of autoimmune process that interferes with normal feedback control. Primary hyperthyroidism, also called thyrotoxosis. This is caused by thyroid nodules, thyroid adenoma, Graves' disease, thyroiditis, that means inflammation of thyroid gland. Secondary hyperthyroidism may be attributed to an overstimulation that is also done by the hypothalamus and pituitary, which produce overproduction of TRH and TSH, which make overstimulation to thyroid gland to produce T4 and T3. So overstimulation of the thyroid This may be due to increased production of TSH from the pituitary gland or TSH secreting tumor, or more rarely from overproduction of TRH from the hypothalamus or thyrotropin releasing hormone TRH secreting tumor. Secondary or non-thyroidal hyperthyroidism, that by mean the main cause is not thyroid itself, but the other causes due to TRH or TSH hyperproduction. Here, the main causes of secondary or non-thyroidal hyperthyroidism: carcinoma, TSH secreting tumors, TRH secreting tumors. Hyperthyroidism incidence and risk. The prevalence of hyperthyroidism is far lower than hypothyroidism when there is a comparison between the prevalence of hyperthyroidism and hypothyroidism. The hyperthyroidism is lower than hypothyroidism in the incidence and risk. The hypothyroidism is similar to hypothyroidism, that the boundary is skewed heavily toward female. That means more female at high risk and incident to hyperthyroidism rather than male. Incidence of hyperthyroidism 0.3 to 0.6% of general population. The risk of population for hyperthyroidism include female to male ratio. That means the female have a high incidence and high risk of the population for developing hyperthyroidism by the ratio 5 to 1 against male. Over age, that means over 60. Other autoimmune disorders. This also adds the risk population of or for hyperthyroidism. Hyperthyroidism laboratory finding. When the laboratory result for TSH is found to be decreased below the established reference interval and a free level of T4 and T3 are high, these findings support a diagnosis of primary hyperthyroidism. If, however, the TSH is high and the level of T4 or free T4, free T3 are also high or normal, these findings suggest a secondary cause for the hyperthyroidism. Finally, a decreased TSH with normal level of free T4 and free T3 in the absence of overt clinical symptoms is interpreted as subclinical hyperthyroidism. We go on to table. It's so easy to interpret here and look for this table, which give the TSH, free T4, free T3, and interpretation of the result. This is the laboratory finding on in the thyroid profile. The TSH when is low and free T4 and free T3 is markedly increased or high or with an upper normal. This is the primary hyperthyroidism. When the TSH is high and free T4 is high and free T3 is high or normal, this is the secondary hyperthyroidism. When the TSH is low but T4 and T3 is still within the normal interval, that means subclinical hyperthyroidism. So go on to a practice question. Why would an excessive production of thyroid hormone cause the level of TSH to be low? I mean, why the excessive production of T4 and T3 cause the level of TSH be low? Please select the single best answer. A negative may be due to a negative feedback loop exists that tell us the pituitary to stop production of TSH when thyroid hormone are found in excess. B, a positive feedback loop exists that tells the pituitary to produce more TSH when T3 or T4 is found in excess. C, there is no hormonal connection between the thyroid and pituitary to regulate the production of TSH. This is a far away answer. Okay, sure. Normally, the thyroid hormone T3 and T4 provide feedback only to hypothalamus and not to pituitary, so as TSH is remain low. So what is the single best answer here? By mean that why the T4 and T3 in excess, the TSH become low. What is the reason? Due to increased T4 and T3 and the TSH become low. Really is according to the feedback. Okay, what is the feedback? Okay, right. The primary hyperthyroidism, when circulating T3 and T4 level are in excess, a negative feedback occur to the primary and TSH production is decreased. This is the answer. This is the correct answer. Okay, go on. Yes. Autoimmune disorder of thyroid. What is the autoimmune disorder of the thyroid gland? Here is the overview of autoimmune disorders. The overall prevalence of the development of autoimmune antibodies that target to thyroid tissue receptors or interfere with regulation of thyroid function has been reported to be as high as 1 in 4 adult women. The identification of a specific thyroid antibody through laboratory analysis permit the elucidation of the autoimmune mechanism, and the most common thyroid autoantibodies include thyroid or thyroid peroxidase antibody, TBO antibody, thyroglobulin antibody, TG antibody, thyrotropin receptor antibody, TRAB antibody, and this is also known as thyroid stimulating, because the thyrotropin receptor antibody or the autoimmune antibody work as the TSH, so as make also stimulating to the thyroid gland. In this case also the TR antibody known as thyroid stimulating antibody and have the function similar to the TSH. Immunoglobulins, TSI, thyroxine binding globulin antibody. Okay, what is the TSI? Here by mean immunoglobulins, TSI. The immunoglobulins are IgG antibody that can bind to thyrotropin TSH receptor on the thyroid gland. TSIS mimic the action of TSH, that by means this antibody have a mimic function like TSH. When this antibody have to connect, when this antibody connect to the specific receptors on the thyroid glands, also stimulate thyroid gland to production of T4 and T3, so as the IgG have the mimic function of TSH, causing an excess secretion of thyroxine and triiodothyroxine. The thyroid TSI level is abnormally high in person with hyperthyroidism due to Graves' disease. So what is a Graves' disease? Graves' disease, that autoimmune disorder by production of immunoglobulins, TSSI, thyroxine binding globulin antibody, which have this antibody have a mimic or similar function to TSH, which causing excess secretion of thyroxine and triiodothyroxine, and this is also known as the Graves' disease. TPO, thyroid peroxidase, is an membrane associated protein expressed only in thyroid follicle cells. This enzyme is responsible for the oxidation of iodine or iodide on the tyrosine residues in thyroglobulin for the synthesis of T4 and T3. Autoantibodies direct against TPO. That means TPO is an enzyme influence the synthesis and production of T4 and T3. So when there is an antibody against the TPO, there is a limit in activity of this enzyme, and it is also cause a negative effect on the production of the T4 and T3, which is also known as the thyroid hormone. The TPO antibody levels are their highest in Hashimoto's thyroiditis. So what is the Hashimoto's thyroiditis? Hashimoto's thyroiditis is also autoantibodies against TPO, which make to destroy this enzyme, and this enzyme have a major activity and function to sinuses and formation of thyroxine or hormone glands. When this enzyme is affected by or destroyed by the autoantibody known as the TPO antibody, that cause low production and failure of thyroid gland to produce sinuses of T4 and T3, and also lead to condition is also known as the Hashimoto's thyroiditis. TG antibodies, thyroglobulin antibodies, are directly specific against the globulins proteins that produce and store in the thyroid follicles. It is presence alone is not diagnostic of specific thyroid autoimmune disorder, and is often found in conjunction with other antithyroid antibodies. Determining of TG antibody is essential when monitoring thyroglobulin as a tumor marker for a recurrence of thyroid carcinoma, have a major function in the monitor of the thyroid carcinoma. So this is the Graves' disease, one of the autoimmune disorders due to production of thyroglobulin receptors. Antibody mimic or resemble like TSH, which also make hyper stimulation of the thyroid gland to produce T4 and T3. In Graves' disease, this is a clinical or typical signs and symptoms which presented in the left pictures show the clinicals and signs of the Graves' disease. This also there is oxypolymus, enlarge of eyes, in here sweating, excess sweating, goiter, that mean enlarge of the thyroid gland due to hyper stimulus by the antibodies TRH or antibody TRAB. Arrhythmias of cardiac tachycardia, nausea, and diarrhea due to increased movement of bowel. Oligomenorrhea in females, that mean disturbance in period cycle. Muscle weakness, tremors, headache, weight loss, nervousness, emotional instability. All these are the clinical features and signs of the Graves' disease. It is a symbol like the hyperthyroidism clinical and features, signs and symptoms due to hyperproduction of T4 and T3 due to antibodies, also known as the TRAB antibody. So, production of thyroid stimulating hormone to stimulate thyroid hormone production, which can lead to hyperthyroidism. Symptoms is eponymous, abnormal position of eyes, balls, anoxia and nervousness, pulmonary hypertension, rapid heartbeat. Prevalence of the Graves' disease in female to male about 8 to 1. That means the female have the high prevalence to Graves' disease rather than male. Approximately 0.5% of population likely under age 40 at diagnosis. Usually likely under the age of 40 at diagnosis. So Hashimoto's thyroiditis mechanism. Hashimoto's thyroiditis is autoimmune antibody developed to thyroid peroxidase TPO 90% and thyroglobulin TG antibodies 95%. Highest TPO antibody level found in Hashimoto's thyroiditis, which can lead to hypothyroidism, that by means low production of T4 and T3. Signs include weight gain, inability to lose weight, depression, especially postpartum, prevalence 0.3 to 1.2% of general population in the United States. Female to male ratio about 12 to 1. That means the female at high prevalence of Hashimoto's thyroiditis rather than male by the ratio of 12 to 1. Benign and malignant hyperplasia of thyroid overview. Hyperplasia is the term that most simply stated means overgrowth when applied to the thyroid gland, enlargement of thinner gland, a region of the gland, and a nodule within the gland represent the main distinguish of the thyroid hyperplasia. Hyperplasia, that means hyperactivity and hyperactive of the thyroid tissues and gland. Hyperplasia due to injury, infection, or in response to other inflammatory conditions are categorized as thyroiditis. So, when there is a hyperplasia of thyroid gland due to infection or inflammatory or due to response of infection is also known as thyroiditis. By mean thyroiditis is inflammatory. In some cases, the overgrowth of the thyroid tissue is functional, meaning that the hormone producing cells within the tissue have an increased capacity to produce thyroid hormone. This increased production may be temporary and self-resolved without intervention, and symptoms associated with hyperthyroidism is also resolved. That means by temporary, not for a long time, for a short time, and it's also become okay and come out to the normal. Occasionally, these benign or non-cancerous tissues persist and require medical or surgical intervention. In such cases, the laboratory may be called upon to assess thyroid function in response to therapies. Malignant hyperplasia or hyperplasias of the thyroid are most common found in thyroid carcinoma. Benign hyperplastic conditions that the most common benign non-cancerous hyperplastic conditions of the thyroid are thyroiditis, non-autoimmune disorder due to inflammation, infection, or due to postpartum, which can lead to goiter, gross enlargement of entire thyroid, or just in one lobe. The goiter, that means enlargement of thyroid gland. This enlargement may be in one lobe or maybe in the two lobe of wall thyroid. Nodules, hyperfunction thyroid nodules, toxic adenoma, that means producing high amount of T4 and T3. Toxic multinodulars, that means there is a more than two nodules in thyroid gland which have a hyperactivity to produce T4 and T3. Malignant thyroid hyperplastic condition. According to the National Cancer Institute, the incidence of thyroid cancer in the United States suppressed about 500,000 cases, with approximately 50,000 new cases emerging in 2015. Accounting for 3.6% of all new cancer diagnoses. Despite the increased incidence, thyroid cancer remains highly curable, with a number of deaths at 1 in 200,000 Americans. Because the thyroid is palpable nodules and fairly obvious and often self-detected, that means by naked eye you can detect the nodules of the thyroid gland because there is some enlargement of net in the position of the thyroid gland can be easily detected by naked eye, leading to a relatively early detection. Thyroid tumors are more commonly self-counting or in situ, meaning that their early and complete removal is key to avoid metastasis. Metastases, that mean spreading of the cancer cell to other area. So as the best treatment for thyroid cancer is the surgical, that by me remove the thyroid gland completely so as to prevent or to avoid metastasis, by meaning spreading of the cancer cell into the other area. In these pictures, low pictures show the thyroid cancers. This is a comparison between the healthy thyroid and thyroid cancers. We look here in the healthy thyroid, normal tissues and thyroid bones, cartilage are normal. Here in the thyroid cancers, whole bones and cartilage, so as the thyroid cancer tissues have a highly spreading to the other area, and the best treatment by make to remove or surgical remove of thyroid gland. If the thyroid carcinoma is deemed aggressive and is not self-contained, surgical intervention may be recommended to remove the cancer's growth or occasionally the entire thyroid gland. In a cases where the entire thyroid gland is removed, the physician may use thyroglobulin as a tumor marker to serve as evidence for cancer's recurrence in metastatic tumor. Here is the thyroglobulin have important function to monitoring the patient after surgery, so as to know that if the tumor is completely removed or there is a recurrence of the metastatic tumor. So in this picture shows the normal thyroid, and here is the cancers of the thyroid appear here in the left lobe. This is a thyroid tumor. The best treatment by removing thyroid at all. Okay, we have a practice questions. By mean, beginning hyperplastic condition of the thyroid may be lead to an overproduction of functional thyroid hormone and present with symptoms of hyperthyroidism. Is this sentence true or false? Benign hyperplastic condition of thyroid may be lead to an overproduction of functional thyroid hormone and present with symptoms of hyperthyroidism. Is this true or false? Okay. Yeah. The feedback hyperplasia or increased growth of the thyroid may be cause increased production of T4 and T3, so as give the hyper or signs of symptoms of hyperthyroidism. This sentence is true. Okay, this is the references. We can use it for revision or for more detail about the thyroid disorders. Thank you very much, and I will see you in the next lecture. Goodbye.